Waiting for my co-chairman Dario Olivieri, who will join us in a moment, and anticipating the apologies of Walter Canonica that due to academic responsibility could not be with us today. It gives me great pleasure to introduce Pascal Chanez. Please have a seat. Pascal is a professor of respiratory medicine in Marseille. After a long training and career in Montpellier, has been the mentor of some of our younger fellows, and it's a great pleasure to have him here to talk about his favorite topics. He has contributed so much, the favorite topic being severe asthma, and the title is Phenotypes of Severe Asthma. Pascal.
Thank you very much, Leo. As you mentioned, I am back in my family. We met a long time ago, and still coming back to you, it's a pleasure. And I met so many friends yesterday here that it's very important for me. Thank you very much. And we are dealing with a very fascinating times. As we heard today, we are speaking about comorbid, multimorbid, general diseases, and we are considering to phenotype, that is to say, to go close to a very teeny phenomena and try to better understand and better treat our patients. That is my conflict of interest. And you already see this about what is phenotyping, and it's just a way to consider all these chronic disease. That is the meeting between genotype and environment. So the main problem for me when you ask me to speak about phenotype of severe asthma was to say why. Because we are speaking about comorbid condition, COPD as a systemic disease, and if you can consider asthma is a systemic disease, and if you consider severe asthma, for example, you can count or say the same as Klaus mentioned about COPD, about the numbers of comorbid conditions. So for me, clearly, to phenotype, it's just go in deep to the mechanisms. You know, I am a researcher, and I think that translational medicine is the best way to understand what we are speaking in the clinic. So better understanding, and the term of endotyping is so important because the mechanisms, so you know, the way we are characterizing asthma, severe asthma, all these chronic disease at present is not very precise. It's based on all measurement. And it was said this morning that we are treating exacerbation of COPD as in the 19th. It was exactly the same for asthma. The most important point to phenotype is to predict future risk, because when you see a patient, the parents or even the patient itself, he say, oh, what will be my future? I don't want to have a chronic disease. I want to be cured from asthma. And you say, oh, it will be perhaps, yes, no, exacerbation, decline lung function, dying from asthma. But nobody can predict for sure. So if you better assess the phenotype, perhaps you can say, oh, yes, you will have symptoms during your life, but it will be okay with a little bit of treatment and a better management. We need to save money and to save life and to have a constant need to a better quality of life for our patients. So the main problem is always to define, and if you go through this different task force, consensus, group of people, they just want to say, oh, my definition is the best. because it's mine, and I was part of this consensus. And the last one was the ERS ATS story, and I like this one because I was in. Second, because we consider to produce a severe asthma definition when you know the patient. You can't say, I claim I want to test a drug. I just say, if you have a severe asthma, come to me. You need to have a step-by-step assessment of the disease. And the last, but not least, the last point, dealing with the control asthma, but with an excessive treatment. That is to say, control on continuous oral treatment with oral steroids, which is not trivial at all. And this is very important to consider the weight of the treatment as part of the definition. All the other items, you know them for a long time, that is to say exacerbation, still symptomatic. And from this definition, looking at the French cohort of patients with asthma, we can classify it as well as from the GINA guidelines. You know that it was different from what was previous ATS 2000 definition. That is to say, perhaps with this definition, we can better assess what is severe asthma. What are the meaning of phenotyping? Phenotyping is just because we are facing an heterogeneous condition. But most of the chronic conditions are heterogeneous. So you can say we have different tools and we can classify our patient using these different tools. If you are a genetic people, you can use gene to consider different aspects of the disease. And if you are dealing with a patient or psychology, you can divide the patient according to the psychological status or to the patient-reported outcomes such as health-related quality of life. So it's very important to try to convince people that this way to better assess the different phenotype of severe asthma is valuable for the patient, for the future, and for the understanding. It's not always easy. And it's very important to use the same wording. You know, we are just speaking about, when I begin, they all speak about acute severe. And when we consider severe, it was just the acute exacerbation, people in the ICU. And we are considering now severe as a long natural history of the disease. And the control is a recent events, exacerbation and daily symptoms. And so there is some of these items which are more prone to be variable. And the severity is clearly linked to the natural history of the disease. And it's just a way to remember that we are facing a chronic disease. And all these are important to consider when you are facing a patient. Once again, at the beginning of the story, you can consider a lot of different factors. The age of at onset, some are very clinical, some are very, you can challenge all these factors. Age of at onset, for example, and you have this concept of early or late onset of asthma, which is quite critical because you can say that most of the time you are completely unable to know exactly when the disease begins. When you are considering pathology, for example, and if you have the opportunity to sample small children with asthma, they have already most of the characteristics of the disease. And for them, the perception, the events, the clinical events, and the way to assess asthma is different. So when you report that early onset or late onset is different, perhaps it's true, but perhaps it's just the way you measure the things at a different time. So it's very important. So you can come from very natural, normal, physician-related, even non-specialist-related outcomes to very specialized, very researcher-linked outcomes, such as gene, pathological, immunochemistry, and from this you can classify and phenotype the patient. And you try to correlate. Most of the time when you send a paper, they ask you, oh, what is the correlation with lung function? What is the correlation with an objective measurement when you claim you find a new protein related to severe asthma? And we try to correlate poor control exacerbation mainly to exacerbation to inflammation and smooth muscle. But because when you have symptoms, you relieve symptoms using bronchodilation. So it makes sense that it's due to muscle. Inflammation is most of the time the reflect of the control or the activity of the disease. And when you are considering decline, you are considering distal airways and structural changes. And you can assess structural changes by different ways. The main factor, and it's the limiting factor for all the animal models, it's time. It's a chronic disease. It's the whole life disease. And so when you focus on just of snapshotting the disease using even the best tool, you have just a glimpse to what he's doing. So you can see that in the natural history of severe asthma, you can have period of very important exacerbation, and then you have an airflow impairment, and patients claim different symptoms. So the way to phenotype, usually people use different factors. Oh, sorry. And the most used symptom factor is allergy. And in that particular study, we were able to show that there was less allergy in severe asthma than in mild asthma. The other way is to use triggers, precipitating factors. Is it comorbid condition? Nobody knows. For me, nasal symptoms, nasal involvement, it's part of the disease. And in that particular paper, we were able to show that it's very frequent in severe asthmatic. And a real comorbid condition, if you define comorbid condition as a different chronic disease receiving a real diagnosis and needed a real treatment. And if you consider obesity and severe asthma, you can have a lot of different aspects of the disease. And if you phenotype this, you will see a lot of differences. So is inflammation the starting point? And what is inflammation in severe asthma? In severe asthma, if you consider endobronchial biopsy, you can find, even in treated patients, you can find eosinophils still there. And Leo elegantly demonstrates that you can differentiate severe asthma from COPD using a panel of markers using endobronchial biopsy, saying that you can have a different pattern. And it was illustrated by using sputum analysis, all these non-eosinophilic, eosinophilic, neutrophilic, or polygranulocytic inflammation. And on Fumosa, once again, we found that in severe asthma, there was more non-eosinophilic inflammation in the sputum of our severe patient. That is to say, what is the purpose of that? The purpose is just to say that if you have eosinophils, you are more prone to respond to steroids. Point. And the question is more complicated, because why? Some patients with eosinophilic asthma have still eosinophils despite the treatment. And some with mild asthma respond very well to the same treatment. So the heterogeneity is still there, considering the inflammatory pathway. So you can go to another eosinophilic related marker, that is to say alveolar NO, and people found that it was more associated with severe asthma. But in that case, exhaled NO was not. So once again, the inflammation and the location of inflammation was different. So there is an overlap in this phenotype. That is to say, Th2-high phenotype, overlapping between allergy, total IgE, exhaled NO, eosinophil, IL-5, IL-13, and the bottom line and the challenge is the response to steroids. So you have this kind of phenotyping, but it's not completely related to severe asthma. What are the structural changes? I just want to say that for me, severe asthma is an epithelial disease. Epithelium is clearly abnormal in severe asthma, and you can discriminate between severe asthma and mild asthma and COPD from this point. And we were able to reproduce this in an ex vivo model, showing that in an air-liquid interface, you can find more goblet cells, and a dynamic of restitution of inflammation was different. And furthermore, the activity of the epithelium was different. That is to say, there was an unbalance between the release of pro-inflammatory cytokine and the release of the cytokine or the mediator linked to the resolution of inflammation. That is to say, in that particular example, lipoxin, saying that there were a continuum from inflammations in severe asthma, but still there was a defect in the resolution, and pointing out the need to a constant treatment. And this is not trivial, because using this system, you can see the release of other markers, such as extracellular matrix components, such as periostin. And this was found in our hands, showing that the transcriptomic analysis was able to show that under the IL-13 exposure, the severe asthma epithelium was able to release more periostin than mild asthmatics, indicating specificity of this release. And you know, all this subepithelial layer space under the epithelium, and we found with Arnaud Bourdin that it was quite specific in severe asthma as compared to mild to moderate or to COPD. So there is some structural changes which can represent the structural changes in severe asthma. And as you know, the distal airways is a very important component of the airflow obstruction in severe asthma. And using new technologies such as CT scan, you can quantify gas trapping. And it was shown in that particular study that in severe asthma, this gas trapping was increased and quite specific of severe asthma, indicating once again that we can use this imaging approach to discriminate between the patients with severe asthma. So to finish with, we were doing the physician job so far. That is to say, we are using tools, clinical, imaging, functional, to discriminate our patient. So now, if we can try to use different aspects, that is to say, this is a very interesting study, saying eosinophilic inflammation by sputum and symptoms. And you discriminate, and you try to do cluster analysis. And this is very important because you are primary care and secondary care patient. And they were able to discriminate with what they called a normal phenotype of eosinophilic asthma. Early onset, allergic, eosinophilic, responding to steroids. And on the other hand, they found difficult severe asthma with eosinophilic inflammation not responding to steroids. And on the other hand, patients with obesity, less eosinophilic inflammation, no response to steroids. So they can discriminate their population. And that is helping in the real life, because found on this finding, they can change the way to manage the patient using less or more inhaled corticosteroids. So in that aspect, it was very important to phenotype the patient. And this is not trivial, because if you consider that in obese patients, they don't respond well to inhaled corticosteroids, you can use this comorbid condition to change the way to treat the patient. This was a not unbiased way to cluster the patient. In that US adventure, they use a non-biased way to, they just ask patients for a different aspect of their asthma. They pull all the data together and they cluster the patients using lung function, age of onset, and they have 5 clusters at the end of the day, and these are quite overlapping, as you can see on the slide. But the 5 cluster, for example, the 5th cluster was with patients overlapping with COPD. If you can, there was airflow obstruction, long history of asthma. And if you consider this cluster, they were not related to any of these current markers of asthma, including bronchial hyperreactivity, total IgE, or inflammation related to eosinophils. So you can discriminate the patient with severe asthma using cluster analysis, but the relationship with any of these was completely unknown. And for that purpose, we use a group of severe asthma patients, and we look at the stability of cluster. We use the same cluster analysis as in the SARP study, and we just show if they can predict the future. As I mentioned previously, just to know if you are in a different cluster, you can predict the time for the next exacerbation. But all these clusters were completely superposable to what they found in SARP at the cross-sectional analysis. But none of them was specific to the future. So the stability and the prediction of the next event, and it was a 3 years follow-up study. So what are the therapeutical consequences? Once again, the first one in the real life is if is severe asthma still responsive to systemic corticosteroids? And the answer is yes from this study. If you are sure of the compliance, you can decrease the eosinophil content and increase the lung function. Once again, with Arnaud Bourdin, we found that considering the subepithelial layer, which is quite important in severe asthma, you can predict the response to a short course or steroids, indicating that if you have very important structural changes, you can see some kind of refractoriness to steroids. Once again, if you are considering the eosinophilic type of severe asthma and using an anti-IL-5, such as in that study, we were able to show that a specific treatment with this mepolizumab treatment, you can decrease the number of exacerbations. But in that particular study, we were unable to show any other change in other outcome in this severe patient, indicating that you can target a specific tool, but you can't change all the outcomes of severe asthma. To finish with, the periostin study, which is an extracellular matrix protein, which is a biomarker of the remodeling of the airway in asthma. And this was the first study looking at an anti-IL-13 in asthma, moderate to severe, and which was found that patients with a serum periostin, high periostin, were more able to respond as compared to patients with a low periostin level in their blood, indicating that you can perhaps target and predict the response to a drug. There is some difficulty with this study because there was moderate to severe asthma and there was no way to discriminate between these patients. So the take-home message, the most important, is you need to have a step-by-step approach from difficult to severe asthma, to know the patient, then to phenotype, and perhaps the Graal, the gold standard for phenotyping will be the response to the drug treatment. That will be the ultimate way to better understand. Because if you consider all this, it will be very nice, but at the end of the day, you will be able to consider one patient by one patient, by patient, and only you will say, oh, we are already doing this. As a doctor, you are considering your patient an individual. And I prefer this way, that is to say, in a chronic severe disease such as severe asthma, you need to have a very combined approach, including the clinical research, the cohorts, and the Center of Excellence for Severe Asthma, including translational approach from research to epidemiology. That is my conclusion. We need a new approach. That is to say, perhaps in a day, we will see that we will consider all these airway disorders using imaging rather than calling by clinical data. The main issue regarding phenotyping in a variable and reversible disease such as asthma is stability. Just to say something to my friend, thank you very much.
Thank you, Pascal. Very good lecture. Before question from the floor, one you heard this morning in the presentation of Klaus and also on other subsequent presentation, the importance of comorbidities in other chronic conditions. And the question to you in the overall balance from the variables you included in your definition of severe asthma, what is the weight that you attribute to the comorbidity of severe asthma, and which one are the more relevant?
Nobody knows, Leo.
Okay. All right. Let me rephrase my question.
If I want to be honest, I would like to design a study saying, well, you are considered, according to any definition, as a severe asthmatic. Okay? You have some comorbid condition.
Yeah.
We are not going to test the new anti-IL something or the new treatment. We are just having around the table a panel of people, expert in all comorbid condition. And we will try to say we are going to focus on each of these comorbid condition, and at the end of the day, we will consider the asthma outcome.
Yep.
I am sure we are going to improve the asthma outcome, including the health-related quality of life for this patient. That is to say, we need, and especially in severe asthma, to consider the global approach of the patient, and if the comorbid condition is too important in the control, that is to step by step from difficult to severe, because if the...
No, but I don't want another lecture. What I want to, is from your experience. I mean, is chronic heart failure a relevant issue? Is thromboembolism, is pulmonary hypertension, is any condition that you not based on evidence, based on your daily practice, is any comorbidities you pay attention to on your severe asthmatic that you are concerned and that you think that may help you to improve?
The answer is if they have...
Don't say if. Give me, yeah.
If they have the disease,
yeah,
you take care, you manage the pulmonary hypertension, and then you see what will be the issue for severe asthma. And for me, it's a prerequisite. That is to say, if you have heart failure plus asthma symptoms, and you consider the heart failure as a major factor to make the asthma uncontrolled, it's not severe asthma at all, Leo.
Thank you. Giovanni.
Thank you, Pascal. Very interesting lecture. I have 2 points. One is related to definition. You showed in a slide that the new definition is quite more homogeneous to the definition of GINA and different from the previous ATS definition. 3 or 4 years ago, a panel of WHO released a new definition of severe asthma. Have you made any thought about the comparability of the new definition of the ERS ATS task force with the WHO definition? And the second point is related to the issue of prediction of outcome. As far as I have understood, you have showed many different attempts looking at biomarkers, etc., with no real success in predicting the outcome for severe asthma. I was thinking that there is a component which today we are going to call exposome. There is an attempt to try to reconstruct the environmental exposure of an individual. There is a new European Union project going on that. And I was wondering whether in the clinical trials, in a way, there is some thinking of trying to look also to the exposome in order to try to predict the outcome for severe asthma.
Yes, it's a good point, but once again, the answer is the same as for Leo. That is to say, if you maintain a real trigger in the environment, and if you are able to prove that the trigger is related to the uncontrol of the disease, you need to remove it before saying it's severe asthma. It's the same as, can you consider a smoker asthmatic as a severe asthmatic? The response is yes and no. But you need to know exactly what is the weight, and always that is the difficulty of the task and the difficulty of the answer to balance between the impact. But if you have a real factor in the exposure, you try to retrieve it before saying it's still the step-by-step going to severe asthma.
Thank you. Thank you, Pascal.